So it's really a pleasure for me to be here with you all this morning. I'm sure after the long line of doctors before me, your heads are probably all spinning with the amount of information you received. Fortunately, much of it, what I'm going to say, you've heard about from either Dr. Vinay talk or Dr. Stiff's talk. And we'll try to just slow it down, keep it simple. As Pat mentioned, I'm a specialist in treating Hodgkin and Hodgkin lymphomas. And so what are lymphomas? Well, these are really cancers that are derived from cells called lymphocytes. These are normal immune cells, B cells or B lymphocytes, T cells or T lymphocytes. And their normal job is to help us prevent infections and to fight infections when we have them. But like any other cell in the body, these lymphocytes can acquire damage or mutations that allow them to grow without stopping. And then you have a lymphoma. Two large branches, many of you probably are aware of. The larger arrow is not my lack of PowerPoint skills, which I do have a lack of, but just to reflect the fact that non-Hodgkin lymphomas are much, much more common than Hodgkin lymphoma, and we see them much more frequently. Hodgkin lymphoma is really a fascinating disease identified originally in the 1800s by Thomas Hodgkin, because it's got these really weird-looking tumor cells, and we didn't really know what these tumor cells were until the early 1990s. But these are actually B cells that don't look like B cells to pathologists under the microscope. There are a number of different flavors of Hodgkin lymphoma. It doesn't so much matter. We treat them all the same way. And this is typically a disease of young people. We see this in folks in their 20s and 30s, but there's a second peak in folks in their 50s, 60s, and 70s. We only see about 8,000 cases of Hodgkin lymphoma every year, so it's uncommon, pretty highly curable lymphoma with chemotherapy that we use today. Now, the non-Hodgkin lymphomas, a little bit more complicated. I think there's upwards of, 40 or 50 different types now, so it makes my job interesting and complicated. The most common lymphomas are diffuse large B-cell lymphoma and follicular lymphoma. But rather than getting too complex, I like to think of lymphomas into sort of three baskets. We got ones that grow slowly. Those are called indolent lymphomas. You may have heard of follicular lymphoma, or as Dr. Vinay mentioned, chronic lymphocytic leukemia. These lymphomas are typically slow growing. They need treatment every now and again, but generally behave pretty nicely. And then we've got our aggressive lymphomas, and the prototype there is called diffuse large B-cell lymphoma. That's the most common non-Hodgkin lymphoma. And these are typically associated with symptoms. Many of them are often curable, particularly diffuse large B-cell lymphoma. And then we've got lymphomas that are truly explosive. They grow you can watch them grow. Sitting in clinic with a patient sometimes, that's not actually true, but they grow over a period of days. And these are your Burkitt lymphomas and your lymphoblastic lymphomas, right? And so these are the latter two groups are also treatable and often curable with the treatments we use today. And so how do we, when sitting down in clinic, how do we figure out what to recommend to you to treat your lymphoma? Well, it's based on, obviously, the type of lymphoma you have. The treatments for slow-growing lymphomas are different than those for fast-growing lymphomas. The stage of the lymphoma, meaning how much of it there is, where the lymphoma is. For example, lymphomas that involve the brain or the central nervous system require different types of treatments. How old are you? How many other health problems do you have? What other medications are you on? This is important to consider because folks who are older, again, have, as Dr. Burns mentioned earlier, tend to have more health problems, be on other pills that can increase the side effects of the medicines that we deliver. The convenience. Why would I give a chemotherapy once a week when I can give another one every 3 weeks and the effect is the same? And then importantly, more and more, we're taking into account genetic features of the cancers, specific mutations that we see time and again in a particular lymphoma subtype that we can actually target with a pill or with another type of therapy, so that we're not treating all the patients with the same type of lymphoma the same way anymore. And so lymphoma is interesting because it's a disease in which we use all sorts of treatments: chemotherapy, radiation therapy, immunotherapy, you heard about some of that from Dr. Stiff, targeted therapies, and sometimes no therapy, depending on the type of lymphoma you have. And so we know that we've all heard of chemotherapy. Nobody likes it, including myself, but it is pretty effective in lymphoma. And in lymphomas, we typically use cocktails of medications, each that works by a different mechanism to kill your lymphoma cells. That, number one, leads to maximal effect, and number two, reduces the likelihood that these lymphoma cells then can acquire resistance if we're hitting them in multiple different ways at the same time. We like to use acronyms to confuse you so that you think that we're smarter than we are. And so these are some of the cocktails you may have heard of. Not that you need to remember any of them, but this is pretty typical in lymphoma. Unfortunately, with chemotherapy, I'm sure many of us, at least in the room, are familiar with its side effects: fatigue, nausea, decreased appetite, low blood counts. And these are sort of general chemotherapy-associated side effects. And then there are those that are unique to each chemotherapy as well. So, it's manageable, but not a whole lot of fun. What about radiation therapy in lymphoma? This is, I think, in the past 2 or 3 decades, taken largely a step back. It's used often in early stage lymphomas where you have a single lymph node that's involved, so radiation can be very effective there. And sometimes it's used to boost the effectiveness of chemotherapy. There are some acute side effects or short-term side effects, not that different from chemotherapy, some fatigue, nausea, vomiting. And then long-term side effects, such as the risk for developing secondary cancers in the area of the body that was radiated. And so what about some of the newer therapies that we're using to treat Hodgkin and non-Hodgkin lymphomas? I think you heard from Dr. Vinu about monoclonal antibodies, and these are just antibodies that many of which were made in a mouse initially many years ago that sort of coat the surface of our lymphoma cells, and that new coat that's delivered or that's provided by the antibody signals our immune cells to recognize and eat those lymphoma cells. And these monoclonal antibodies, mostly that target this protein, it's called CD20, are used routinely in all B-cell non-Hodgkin lymphomas. Another type of immune therapy you may have heard of in the papers recently is called checkpoint blockade therapy. And this is where we administer antibodies that work by activating your own immune system as it stands in your body to recognize and kill cancer cells, including lymphoma cells. And these drugs have really changed the entire treatment landscape, not only of lymphoma, but other cancers as well. And then I won't talk too much about CAR T-cell therapy because you just got a nice review. But this is obviously where our own immune cells are taken out of the body, modified, and then given back to us once they're rendered specific for our lymphoma. So it's a little bit different than checkpoint blockade therapy. And then we've got targeted therapies. What does targeted mean? Well, I don't know if anybody really knows what it means, but these are drugs that act against specific pathways that we know drive the growth and spread of lymphomas and other cancers. I think you've heard about all of these in previous chats because many of them are very effective in diseases like chronic lymphocytic leukemia or CLL. Drugs like ibrutinib, which targets a very specific pathway in CLL. But this drug is now also widely used across lymphomas, lymphomas like mantle cell lymphoma, marginal zone lymphomas, Waldenstrom's, and in some cases, diffuse large B-cell lymphoma. And then lenalidomide, which you heard about, I think, from Dr. Hagen in the myeloma chat. This drug is also active in several lymphomas. There's another class of drugs called PI3 kinase or delta gamma inhibitors, drugs like duvelisib or copanlisib. These inhibit a similar pathway as ibrutinib. The nice thing about all these drugs is that they're pills, so you don't have to come to the infusion center to get the intravenous chemotherapy anymore. But these drugs, unlike chemotherapy, target very specific alterations that we see over and over again in certain types of lymphoma, and these are all used more and more widely. So when I came out of training, I guess, when was it? 2009, I guess, there really wasn't a whole lot going on in lymphoma. But if you look at the number of new drugs used to treat lymphomas since 2013, I think I counted this morning over a cup of coffee, there's like 12 or 13 of them, maybe more actually. And so every year there are new drugs. Some of them are targeted therapies, some of them are immunotherapies that we have in our armamentarium to help fight your lymphoma. And many of these drugs are as effective and less toxic than the classical chemotherapies that we've used to treat lymphoma for many years. I expect that this number will only continue. Now, what about lymphomas that have come back? Many of the aggressive lymphomas that we see, Hodgkin lymphoma, diffuse large B-cell lymphoma, are quite curable, but sometimes they do come back. When that happens, we call that relapse. And so how do we treat these lymphomas? Well, first, what does refractory mean? I think we use these terms as doctors and assume the world knows what they mean, but they're our own little jargon. So refractory means a lymphoma that you treat, but it doesn't go into hiding. So the treatment essentially fails to work. Whereas a relapse is the return of a lymphoma or another type of cancer once it went into a remission or once it went into hiding with treatment. And so we know with aggressive lymphomas that relapses happen more commonly within the first couple years after a patient finishes his or her treatment. After that, the risk for recurrence gets much lower. With the slow-growing lymphomas, there's an ongoing risk for relapse. These are very treatment-sensitive lymphomas, but we know that these lymphomas are going to stay in remission for a period of years. Could be 2 years, could be 10 years, but they're going to come back. And we know that as oncologists that we're going to have to treat these slower-growing lymphomas time and time again. But we know with more modern types of therapy for these slow-growing lymphomas, CLL, follicular lymphoma, that over half of patients remain in remission even at 5 years from their initial treatment. So this is pretty good. It's not perfect, but it's pretty good. So when lymphomas come back, we often treat with second-line or what your doctor might call salvage therapies. And there's some more acronyms down there. These are kind of intensive chemotherapy regimens. Sometimes we'll use targeted therapies. But the goal here really is to get your lymphoma back into remission. And why is that important? Well, because we want to do a stem cell transplant. And stem cell transplants, whether it's a self-transplant or a donor transplant, they work better when your lymphoma is in hiding. So the less lymphoma you have at the point when you're transplanted, the less likely it is to come back after you're transplanted. So we want to show that this disease is chemotherapy sensitive, which means it shrinks down when we give you these types of chemotherapies. And so what about transplantation and lymphoma in the 2000s? Well, we still use it, and it can be quite effective and curable in a fraction of patients. And so what are they? So these are just procedures that allow us to give you high doses of chemotherapy that would otherwise kill off all your bone marrow cells, and then to rescue your bone marrow function by reinfusing either your own stem cells in the setting of an autologous transplant or a donor's stem cells in the context of an allogeneic transplant. And as I mentioned, these are typically used for aggressive lymphomas that have come back after the initial treatment, okay, either B or T cell lymphomas, occasionally Hodgkin lymphomas. I think less and less use allogeneic transplants and even autologous transplants in lymphoma, even indolent lymphomas, because we have more options available to us. Especially for, as I said, for these low-grade or slow-growing lymphomas, I transplant less and less patients because I have more and more other options that are less expensive and less toxic to use. So this is, I didn't see Dr. Burns' whole talk, so I hope I'm not repeating everything here, but this is kind of the procedure, a cartoon that outlines the autologous transplant procedure. Basically, you're given medicines that get your stem cells out from your bone marrow into your peripheral blood. We put IVs in and we collect them. We count them and we freeze them. And then you come in the hospital usually, get high doses of chemotherapy. After that's done, we reinfuse your bone marrow cells, or your stem cells, I should say. And that allows the blood counts to come back about 2 weeks later. It's a pretty tough period of time. Maybe some of you have been through this procedure. And so the donor transplant or allogeneic transplant procedure is quite similar. The only difference is the donor. The patient, him or herself, still receives that conditioning chemotherapy, to bring down his or her own immune system, and to make space in the bone marrow for the new donor immune system and blood system to come in. Okay? The only difference is that we have to bring down the immune system in the context of a donor transplant, because even though we do a lot of typing or matching, we know even with a brother or sister or an unrelated donor who we may say is perfectly matched, it's not quite exactly true. And so that donor immune system, that new immune system that we hope fights your lymphoma or leukemia, also may recognize your tissues as foreign and make an immune reaction, which is called graft versus host disease. So in a donor transplant, we need you to take a pill to keep down your immune system for a period of months or sometimes longer. And so when do we do allogeneic or donor transplants in lymphomas? I think, at least in my practice, less and less. Dr. Stiff may disagree, but I think, again, because we have other options, including CAR T-cell therapy. But classically, donor transplants have been done after patients have had an autologous transplant and the lymphoma has come back yet again. Now, the newer techniques that we use to reduce side effects, for example, are called non-myeloablative or reduced intensity. And this is just a fancy way of saying you get less doses of chemotherapy, and we can still make the transplants work. The advantages of donor transplantation are that you're getting a graft from somebody who doesn't have cancer, presumably, right? So there's no chance of contamination of the donor graft. And the other effect that I mentioned is that the donor graft has an immune system that's a little bit different than yours and may be able to recognize your cancer cells, whether they be lymphoma or leukemia cells, as foreign and make an immune response against them and kill them. Okay. The downsides are that sometimes it's tough to find a good donor, and that there's a risk for these immune reactions called graft versus host disease and other infections. So why would we use an autologous transplant over a donor transplant? Well, it's readily available. You're your own donor. There's no risk for that immune reaction that I mentioned called graft versus host disease, and there are less complications. I think Dr. Burns highlighted that. The disadvantages of an autologous transplant are that sometimes the graft is contaminated by cancer cells, even very few numbers of them. And there's really no graft versus tumor effect. The only benefit of a self-transplant is that it rescues your bone marrow function. There's no magic to that transplant with regard to fighting your cancer. And that we know with self-transplants, the risk of your cancer coming back or your lymphoma coming back afterward are higher than they are after donor transplants. And so in the last minute, I'll talk just very briefly about CAR T-cell therapy. Dr. Stiff outlined the procedure, but basically it's where we take your T-cells and make them recognize your lymphoma cells using a special virus, okay? The nice thing is that it's specific for your lymphoma for the most part, okay? These T-cells, after they're made, they recognize your lymphoma specifically. This is sort of the procedure where just like a transplant, your blood cells are taken out, they're sent to a company, they isolate cells called T-cells that are in all of our bloodstreams. They they engineer those T-cells to be specific for a protein on your lymphoma cells called CD19. During that process, the patient receives chemotherapy to sort of prepare his or her body for the infusion of the CAR cells and to help them grow after they're infused. So it's not terribly dissimilar to a transplant procedure. This is a response, and I think this was the first person I treated with CAR T-cell therapy a couple of years ago. You can see on the PET scan on the right all that black area in the patient's right chest and lung, pretty nasty. After treatment, the PET scan is totally normal. That little black area in the middle is the heart, and that's normal. So you can see very rapid responses, extremely rapid responses, even in patients who have lots and lots of lymphoma to begin with. And her PET scan 6 months after treatment remained negative. So just like Dr. Stiff said, the nice thing about CAR T-cell therapy in these relapsed aggressive lymphomas is that we think it can cure people. We can't say that about many of the other treatments that we use. So I think that's one real benefit of CAR T-cell therapy. Yes, it's expensive. Yes, it can be toxic. But it can also be incredibly effective. And I've personally seen what I would call miracles. So anyway, last couple slides. So what are the directions? How do we make treatment in lymphoma better? Well, how do we improve the results of current therapies? For example, how do we incorporate new drugs with standard regimens? R-CHOP is a common one that we use for aggressive lymphomas. It's been that way for years and years. Can we add a new drug to it to make it work a little bit better? Can we use our new genetic technological advances to sort of risk stratify patients, identify those that are more likely or less likely to relapse, to identify new targets, and then hit them with drugs that induce less side effects and work longer? And so maybe the last slide I'd like to just bring up, and these are things you may know already, but what are questions that you might ask your doctor if you've been diagnosed with a new lymphoma, or if you've had a lymphoma that's now come back? So things you want to know is, what kind of lymphoma do I have? There are 50 kinds. Which kind do I have? What's the subtype? What's the stage of my lymphoma, meaning how much of it is there and where is it in my body? What are my treatment options? Don't just tell me what you think I should get. Are there other options outside of what you're recommending? Sometimes doctors have the tendency not to be in a rush and maybe not to go through all the options that a patient has. And what are the side effects I can experience with the treatments you're recommending, doc? And how can I best deal with them? And then, are there any clinical trials I might be eligible for? Hey, I hear what the standard treatment is, but do you have anything that is interesting that might be better? And then finally, for folks who've got recurrent lymphomas, when is a stem cell transplant or CAR T-cell therapy appropriate for treating my lymphoma? And so I'll stop there, and then maybe we can do questions at the panel. Okay, thank you very much.